Okay, I think we can slowly start, and my colleagues will keep admitting the participants as they are joining. So I'd like to welcome warmly everybody to our webinar today, to our meeting actually, which comes under the umbrella of European Patient Ambassador Program. It's a series of events that we've been running for the last couple of years. I will give you a small introduction before we move to the panel of our speakers. So it's just a small house rules, just to invite everybody to keep their mic muted while people are presenting. But we want the session to be interactive, so please use the chat, introduce yourself, your organization. If you have some comments and questions during the presentations, please put them in the chat, and we're going to have a dedicated session in the end to discuss. But also, if you have immediate questions, you can address them to the speakers after their presentations. Just for your information, the session will be recorded. The session will be recorded, and you will be able to watch it or share it with colleagues, the link to the ELF website. So maybe you see the logo in the bottom of the slides, and the top of the slides, Lungs Europe. Just give you a quick introduction who we are. That's a partnership of European Respiratory Society and European Lung Foundation. And we've come together to work, represent health professionals and patients, to work together from our Brussels office on EU projects and work on policy initiatives. The brand of the event today is EPAP, as I mentioned. And what is EPAP? It's our dedicated program for patients, a European Patient Ambassador Program. And it's a free online source that introduces patients and their carers to some basic skills and knowledge, how to represent themselves and others successfully. And advocacy module is a big part of this program. And that's why we are holding this session today, to actually have more of interactive format of meeting and be able to ask questions and exchange experience rather than just follow the online program. So I'm going to give a very quick introduction about why we are doing advocacy as patient organizations, as health organizations. So first of all, the goal, of course, is to influence policy and decision-making. We can feed the priorities of patients and highlight some health issues at the UN national level. We can influence budgets and which priorities goes to laws and regulations. So we also raise awareness and try to drive change. So we all have, as organizations or individual advocates, we have our priorities, and we can try to mobilize public support for some of these critical health issues. We also all are striving to create patient-centered care in Europe. And I think that's extremely important that patients and everybody who is involved in healthcare are in the center of this process and involved in the advocacy. And it's last but not the least mentioned here, I think a lot of the organizations know the struggle of the capacity and funding, and advocacy can also help us secure funds to do this work. So what does it mean in practice to do advocacy? I think many of us actually do it maybe without having it as our main task in our job description even. But I think for a lot of European organizations and health organizations, that's already a part of their work. So as examples here, you can see policy briefs and some reports that provide evidence-based information to policymakers, conducting public awareness campaigns to secure the support of the public. It can be direct lobbying and stakeholder engagement, reaching out to the government officials and policymakers to advocate for health priorities. And around others, you see grassroots mobilization to actually try to involve patients, caregivers, and wide society for collective voice to create this positive change in healthcare. So today, as one of the titles, like subtitles, subtopics of our event, that we would like to focus on is the split, and this a bit of controversy that Fraser will cover more in his presentation, between the health competences between European Union and national level. Here I just give like a few examples as an introduction of what topics lay with the power of the European Union. These are usually overarching priorities such as public health protection and like such cross-border health threats like pandemics or antimicrobial resistance, health policy coordination, where EU puts down some global strategies and some recommendations for the member states. Regulation of medicines and medical devices is also one of the topics at the EU level, health data and research, and cross-border healthcare. So what do we have left at the national level then? Well, actually, it's all of the practical things, all the implementation. So healthcare delivery, first of all, and the financing. Health workforce management, which is a very important aspect, as well as disease prevention and control, and health legislation. So we'll have some examples today of EU directives and EU recommendations, which afterwards have to be actually implemented at the national level. And we see how it works out or doesn't work out and where the challenges lay. So before I pass the word to our speakers, I wanted to invite you to get involved in our advocacy work of European Respiratory Society and European Lung Foundation. So there are a few ways featured here how you can get engaged. If you're a patient organization representative, you're very welcome to join one of our patient advisory groups or thematic groups. We can keep you up to date about our upcoming advocacy events, where you're very welcome to share also your initiatives and your work. We are also constantly following many health policy files, and you're welcome to also contribute to the consultation and stakeholder consultation processes and submissions that we are working on, especially relevant for the field of respiratory health in our case. And if you have some ideas potentially about about different comorbidities and overarching health determinants for a statement, a letter, or a campaign, you're always very welcome to reach out to us, and we can figure out the ways to collaborate. So without further ado, I would like to present our today's speakers, and our first expert is Fraser Goodwin, who is a Senior Communication and Advocacy Manager from European Public Health Alliance. He studied human ecology, a holistic interdisciplinary study of humans and their environment. And he worked for many years in transport, environment, development health, children's rights spheres for more than 25 years. And he has a wide experience in roles in advocacy, campaigning, and communications. And in his work, he's striving for improved environmental protection, greater social justice, and better health. So I'm going to pass the word to Fraser, who will share his view on today's topic and some examples of the APHA work.
Thank you very much, Paulina. Yes, I'll also share my screen because I too have a short PowerPoint. Let's see if I can share my screen. Right. Hopefully you will see that.
Yes, we see.
And in correct view. It's always problematic that whether or not you're going to be seeing the correct view. Okay, so what I want to focus on is, in many respects, this vision that there is two ways of working for advocacy, one at national level and one at an EU level. And I'm going to question whether that is accurate, that actually work at national level is a vital component of work at a European level, and that you all at a national level have a vital role to play to make and advance EU advocacy campaigns and make them functional. So I also want to underscore this is not the answer, that there is no one template at which you just apply it and everything functions. I'll provide some answers, not the answer. because one approach is unlikely to work on its own. You need multiple different types of approaches at the same time. And that means you need adaptability and flexibility, and also partnership. You need to work with a lot of other different people and different organizations, sometimes organizations beyond your comfort zone, who are a little bit potentially awkward or contrarian to your actual vision. And that will actually make your messages much more powerful and impactful. And I hope to provide a couple of things basically with my presentation, a couple of examples of policy areas where this has worked, and potentially a little bit of inspiration, we hope. But what I don't want to do is teach my grandmother to suck eggs, as we say in English. And that is, I hope I'm not being patronizing and aiming too low. So if my information is very, very basic and too basic for you, my apologies. I'm trying to reach as many people as possible, many of whom have very little engagement with the European Union and its decision-making processes. So let's go to that. Well, I think it was the United States and actually Trump's cabinet who posed this question. The big problem they have is, if they have a big problem, who do they call in the EU? Who is it that runs the EU? Who are you going to call? And just like Ghostbusters, who you're going to call, the answer is not one person, but a team. And in the EU, we have a situation where we have 3 presidents with 4 headquarter buildings in 2 countries. So the EU is a very, very complex and difficult institutional arrangement in which to relates to as an individual or as a policy advocate. It's not a simple, straightforward arrangement where you can identify immediately the target for your advocacy. Additionally, it really is a political balancing act between those different institutions. Each one of those institutions, the Commission, the Council, and the Parliament, all think of themselves as the most important or the most legitimate, and they all try and have the biggest say. So it's a real political balancing act, but not just between the weight of every institution. It's also a political balancing act between how much of the solution to any particular problem is an EU decision, and how much of it really is a competence of the member state, how much should be decided at a national level. And as we've already heard, frequently health policy is viewed as the sole reserve of the member states. Now, I'm going to challenge that notion in the rest of my presentation. And to do so, I'll invite people to think of what is the EU, what is the project. And it's a sharing of sovereignty. The member states have come together and realized that together they can share some of their sovereignty, some of their competence, creating a competence at a joint level, which enables better and more effective action amongst themselves than they could possibly achieve on their own. So it's very much a shared vision that together we are stronger. That in itself means that where the different levels have exclusive competence can get really, really blurred. As we've seen and heard, it's thought that the member states have exclusive competence for several areas of healthcare. Meanwhile, the EU has exclusive competence for many other different areas, the most important and significant of which will be the single market and ensuring compliance of the 4 freedoms. Now, people in Britain have heard about these 4 freedoms during the Brexit debacle, but they are a very strong theme that runs throughout all areas of public interest. So whether that's to do with the free movement of people, the free movement of goods, the free movement of services, the free movement of money and finances, All of these things impact in a great many different ways the way in which healthcare can be served and delivered. It's also the case that we ask for health in all policies as a mantra. And that also means that all of those policies relate and react to healthcare and its competency. So instead of seeing the exclusive competence of the member states, I argue that there's only real exclusivity in the EU dimension, and that member states always have to be cognizant of that. Plus, member states actually give up their competence and give up their sovereignty in extremis. When push comes to shove, during the pandemic, for example, they realized that common procurement of vaccines was more effective than them all trying to secure their own supplies independently. There was no legal basis for joint procurement, but that didn't prevent it happening and didn't prevent it going ahead and helping an equitable or more equitable distribution of vaccines across the EU than had been the case had all the member states acted independently. So it is the case that it's not necessarily also what the treaty says, but what political convenience dictates as to where and when sovereignty is pooled and sovereignty is exclusive. So the political balancing act, back down to reality. Where are you for action? Do you need to implement something that member states are required to at a European level? Is there something that the EU is forcing you to do? Or is it the case that member states are asking the EU to do something because they need help and assistance, and they realise that the EU is more effective as a joint enterprise than they could be on their own? Well, in actual fact, that is a bit of a false way of looking at it, because it's a policy cycle that any individual topic or policy goes around and around in a policy cycle where member states implement a policy. The implementation demonstrates that there are gaps in that policy, that there's some problems that have emerged. And increasingly, they look to the EU to solve those gaps, to solve those problems. And as that recognition grows, the demands that they all have increase for the EU to solve this problem. The Commission then proposes a solution, and a negotiated answer to that problem is then found. But then, of course, when it's found, the member states need to implement it, and round the policy cycle we go. So it's not the case that there's one or the other, whether it's top down or bottom up, but it's a case of when is the question being posed. What point in this cycle are we as to where you're more likely to see activity and action and also change. So I'm going to give two examples of policy areas where EPA, and we haven't been alone, but EPA have traditionally been active, where this policy cycle has brought in national actors and also inside Brussels advocacy. The first is tobacco control, and obviously ERS has been an important partner, and as a member of EPA, an important player in our own advocacy on tobacco control for the last 30 odd years. But we've done so on the basis of two other levels, not EU levels, but national level. First of all, because especially smoke-free environments were first pioneered and championed at a national level by Ireland, and also at a global level because of the WHO Framework Convention on Tobacco Control. Now, the Framework Convention didn't come out of nowhere. It was as a result of many different national demands for the WHO to take action. The WHO doesn't do anything without the clear mandate of its member states. And so the fact that the member states were demanding action in the nature of a new treaty was largely dependent upon national campaigns in many different countries being effective and gaining traction. So both the national action at a European level and a global campaign meant that EU tobacco control grew and developed. And we now have a situation where there's a whole range of different ways in which tobacco control is been enacted at an EU level. Some of those actions have a longer standing than others. Some of those areas and actions need to be revisited and strengthened, but we do have a comprehensive framework for action and for policy that the member states have to abide by or are guided towards improving their own actions. So how did it work, and why did it work? Why was it so successful? Well, the first thing to say that it took time. This was an overnight success of more than 2 decades in the making. This was not something that you clicked your fingers and immediately happened. There was a lot of effort at multiple different organizations, multiple different stakeholders over a very, very, very long period with an enormous amount of perseverance for the policy framework to be put in place and for it to function. The second thing was that there was multiple levels of actions, that there was really effective national campaigns, some more effective than others, and they linked together both at a European level and a global level to really, really see change happen. Without those effective local national campaigns, no progress would have been possible at a global level or at a European level. It was also the case that we were able to really mobilize effectively the science and research community to support evidence-based policy. We really were able to bring forward, first of all, the science and evidence of how tobacco was harmful, why smoke-free environments were necessary, why tobacco control and restrictions on access were needed. But it was also the case that we could show how policies had worked, the science and evidence of how policies at a national level were working, functioning, and then needed to be replicated and extended elsewhere and to a European level. And we worked in broad coalitions with many different types of groups. Importantly, those groups worked alongside the strong supporters we had inside the institutions, both parliamentarians at a national level and in the European Parliament, but also very strong advocates within senior positions inside the European Commission. Without their support, it would have been much harder to gain traction and use that science and evidence to really make a change at a policy level. And then finally, we really were beneficiaries of very coherent and consistent media engagement. So having the issues raised in a very consistent manner at a national level in big media outlets year after year really drove home the message that action was necessary and needed. So that was all why tobacco control functioned to the extent that it did. So now I want to talk about air pollution. And air pollution, you can split into two. First of all, there's emissions control. What can Europe do to set standards on the emissions of air pollution? And there's a variety of different ways it's found to do that, all of them driven either by the single market or by the environment articles of the treaty. However, all of those environmental mentions, all of that environmental legislation is based on action that took place decades before environment was mentioned in the treaty. So the first vehicle emission standards type approval for vehicles was Directive 7220 from 1970, 20 odd years before environment featured in the European Treaty when the Maastricht Treaty came into force. So again, it's political convenience and expediency that drives what is possible, not necessarily what is in the treaty. So always look to politics rather than necessarily what the treaty says if you're going to be effective advocates. And then secondly, air quality standards. Now, air quality standards complement the emissions controls. The emissions controls are what Europe can do to reduce the level of air pollution, but they're not providing clean air yet. The member states still need to do other actions beyond the end of pipe solutions that the emissions controls delivers. And the way in which it was thought that could function would be to provide a framework whereby real-time accurate air quality information is provided to citizens in complete transparency. So they know that there's health damaging air pollution, and so they will demand action from their national authorities. Now, how did all of that work? Why did it work? Well, strangely enough, exactly the same bullet points can be made on air pollution as they could on tobacco control. That the reason it worked was that it was a long-term process. It required lots of national campaigns, multi-level campaigns linked to the climate change issue, so a global dimension too. It was very much based on science and evidence and broad coalitions, alongside making sure that people inside the institutions were on board and supported by consistent and coherent media engagement. So the two areas share enormous amounts, but there's a big but, and the big but is there's been a rollback in science and evidence for both of these policy areas. That there's been a weakening of the reliance on evidence to further both policy fields. Commercial actors have changed tactics and divided and split the coalitions that promoted progress in both fields. So you have the vaping issue has been problematic in tobacco control, e-mobility, and I would also argue Dieselgate, the VW gate, there's the scandal of chip tuning for vehicle emissions, has shown how commercial actors have undermined the regulations that have been agreed. And both issues are now very much front and center of culture war debates with populists of the right who have been mobilized to undermine health messages, whether that be on tobacco control and smoke-free, or whether that be trying to control air pollution via things like the 15-minute city, or controlling vehicle mobility. So it's very much a touchstone issue in both policy areas of this culture war debate. And also, as a result of that culture war debate and the rise of populists in political representation, the institutional support for progressive action has become a little bit more patchy, and political will at the highest level has been weakened, and people are a little bit more reticent about taking strong action on both topics. And another feature of that direction has been inconsistent and incoherent media engagement, especially negative messages against the progressive policies we'd like to see on tobacco control or on air pollution have been a large feature in many media outlets now. So what are my three key messages that we can take from all of this? Well, deciding on the relative importance of national against EU action is a time-dependent, not a topic-dependent balancing act. It really depends on what part of the policy cycle the aspect of the issue is as to where you're going to get more impact. And both dimensions are important to some extent all of the time. It's not one or the other. Then also Brussels decides isn't a full explanation. Brussels may be where the vote has taken place, but the decision of how any member state is going to make their vote is taken in the national capitals, and national level action is very, very key if you're going to get European progress. And effective change is also a very long-term process, and it requires collaboration across different actors in different ways at different times. It's not something you can cook up instantaneously, but you need to make sure that you have a long-term engagement. But that long-term engagement can provide great dividends. And with that, I'll say thank you.
Thank you very much, Fraser, for this this outline and this very comprehensive explanation of the whole policy cycle and where we can make a change. And yeah, with these two examples especially, and we're also very alarmed about political climate we are currently in. So it's also very, very timely that was mentioned. I just wanted to check if there are any immediate questions to Fraser. But we will have a discussion part in the end. But if there's something that needs clarification at this point, we can take one question if there's anything. Otherwise, I will move to our next speaker, Brian Ward, who is a director of Advocacy and European Affairs at the European Respiratory Society. He has been working in policy to improve lung health for over 15 years, and having worked previously at the European Commission and European Parliament, he has a background in EU policy and political process. He has a degree in EU law and politics and international relations. And Brian, over to you. Would you prefer me to share the presentation?
If you can, thanks.
Yep.
I think Fraser has explained a lot there about the interactions in the EU. I'll just give you three examples, some similar examples, but just how we approach it. And it's basically, it's a mixture of proactivity, so initiatives that we come up with ourselves based on what ERS and ELF are interested in, the topics that we find most relevant, and reaction, so reacting to the legislation that's existing in the EU. So here in this slide, you see from 23 to 26, how do we categorize our workflows? So we actually managed to put it into three workflows. So we have environment and sustainability, so that's climate change, air pollution, and related environmental legislation, non-legislative areas. Personal behavior and lifestyle, that's a huge area, but you have all the risk factors for respiratory that we focus on there. And healthcare and early detection being the big focus of our work. So I've put that into three colors, blue, green, and yellow, and I'll just give an example from each of the three. So we go to the blue. As Fraser says, tobacco control has been, since ERS was founded, it's been a priority. It's responsible for a huge chunk of the reason that respiratory disease exists, not for all respiratory diseases, of course, but for a large number. The recent work in the last 5 years, we've just concluded 5 years of a commission and parliament, and the new one has just started. But in the last 5 years, they had a cancer plan. They promised loads of action on tobacco. So, like, talk about over-promising. They said to reduce prevalence 5% target, so by prevalence of smoking by 5% by 2040. In order to do that, you need to do a lot. They have Fraser outlined them there. There's a number of tobacco legislation that they said they would revise in their cancer plan, and basically they did zero. The one thing they did do is they said they would update the smoke-free recommendations. First smoke-free recommendations came in 2009. And we, together with other organizations, did an enormous amount of work on the smoke-free recommendations. They weren't an accident. There was huge investment got into scientific reports. We even set up a massive coalition, the Smoke-Free Partnership. So a massive effort, and you're talking about non-binding legislation at the EU level. And these were fantastic recommendations, the 2009 one. They're also linked in with the FCTC that Fraser mentioned. You had massive support in the European Parliament, very good support in the European Council. And if you contrast that with today, the recommendations barely came out of the Commission. They were delayed for a number of years. Even the day they announced themselves, they postponed it. Basically, they didn't want these recommendations to come before the elections. That's pretty clear. When they did come, they came in September. They were actually quite okay from the Commission's perspective. But the difference between 2009 and now is when these recommendations hit the new Parliament, so the one that's just been elected in June, there you had a huge group of MEPs just against them from the culture war perspective that Fraser mentioned, from a populist perspective, not looking at how can we protect our youth and our children, more like, well, what's going to work down the pub? What's going to work in the constituencies? Germany, for example, has an election coming up. There you would have traditionally the German EPP, so the German Conservatives in the past were quite a lot of them quite supportive of smoke-free legislation. And this time, complete reversal, completely against any update to include new products. So, heat not burn, having these products in around playgrounds and beaches and so on, or having vaping no problem in smoke areas, so the areas where people do go to smoke. The recommendations are saying, well, you should include vapes as well. You should maybe look at beaches, playgrounds, schools, and so on. They're all many MEPs dead against any of this. And you saw that reflected in the Parliament couldn't reach a position on the Commission's proposal. So MEPs wanted to promote vapes in the text, and then other pro-health MEPs said that's not acceptable. So there was no majority. So there was no recommendation at all from the Parliament to have a new smoke-free generation effectively. But despite that, we had the Council agree, and we will have those recommendations. So we do have progress, but not the same as in the past. And this very much, this example, you might say, well, smoke-free, but this is actually a symbolic example for the entire health community if they're awake. This is a signifier for me for the next 5 years that key pieces of legislation and also recommendations will be challenged. From this to vaccines to research funding, etc. It's not business as usual. Voting for populists has elections have consequences is the expression I'm looking for, and we'll definitely see that from a very different commission and a very different parliament, but also a very chaotic council in terms of governments collapsing all over the place and elections in Europe coming up with very complicated results. So next slide. Yeah, and just down on the last slide, as Fraser mentioned, to get the council and the commission to come out with them was an enormous effort, and you can see some of the organizations we joined with here just to get what is essentially not even legislation out. So that's just to give you an idea. Sometimes it can be very complicated just for the most basic things. Next example is from Green, Sustainability and Environment. This is a very positive story, actually. So here on the Ambient Air Quality Directive, we also, like Fraser mentioned for tobacco, we also have an outside framework. So we have these, we worked at every single stage of this. So it's I don't want to spend too much time on it, but there's WHO air quality guidelines, and our experts were on the committees that drove that work. And that was 2.5 years of work. And that was quite complicated work because they had to fight inside the WHO for the best scientific methods. So they're environmental epidemiologists. They know what the best mix of science is. WHO changes its policies and they try to impose a kind of clinical aspect to air quality, which doesn't quite work. So there was a huge back and forth around the science and gathering the evidence that took for absolute ever. So they were part of that process. And the European Commission actually funded a huge part of that process. And that helped the evidence base to support an update of the legislation that we're all affected by. So it's the European Union, but it also is in the neighborhood policy. So any countries wanting to join the European Union have to try and get up to these standards as well. So we inputted into the WHO process, but then also the consultation process of the European Commission at every single stage. So every single consultation, every single workshop, publishing research articles, presenting them. And then we took that work into the European Parliament as well, working with every single political group, submitting amendments at every single stage. So it's quite a bit of work, but to cut a long story short, this was quite a positive example. If you take, there was another piece of legislation going along at the exact same time. I think it was good for us that took the attention. So that was the biodiversity habitats kind of update, where there was a huge resistance. Farmers were strongly against, and because I think a lot of attention went to that, this thankfully got less attention. It doesn't mean they didn't try to water this down. They did in areas, but it was at the right time. As Fraser was saying, timing is often very important in EU politics and EU policy process. This benefited from really great timing, some good presidencies in the council, some good MEPs in the parliament, and right time, right place, and we got it through. Next. Last example is early detection. So early detection is a big priority for ERS because when you look at any of the science of our clinical research collaborations, I'll just take one example. It's the CADSET project. The more you look at the science, the more you see that lung health is a trajectory. So from a life cycle perspective, we know from the DNA and genetics research that it starts in your grandmother and passes through to you. And what does that mean in policy terms then? How can we approach that? And on the one hand, it's getting new diagnostics. On the other hand, it's using old-fashioned diagnostics. So the new diagnostic example would be around lung cancer, where we have great advancements in CT technology, getting better all the time, where you can detect in heavy or former smokers tiny little nodules, get them on the CT scan, get a diagnosis, and you can actually save people's lives for relatively inexpensive terms for the healthcare system. On the other hand, old-fashioned technology is spirometry, lung function testing, and the latest science there is that if you test at certain stages of life, so in childhood and teenage and adulthood, you can detect and prevent way in advance of later life respiratory diseases. So that's a project that we've put a lot of effort into as well. If we take the lung cancer example, I think we have a slide on the lung cancer example. Here this is probably I didn't put years. Fraser put 30 years on the tobacco example. I'd say lung cancer is probably a 7 to 8 year example. So this is a project I worked on for 7 or 8 years. Very, very huge resistance to lung cancer screening in the cancer community, huge resistance to lung cancer screening in the policy community, huge resistance in the health community broadly when it started. So this was a very slow burn, and we built it up very gradually, more evidence coming in all the time from clinical trials, more understanding from the medical profession itself, then gradually the wider public health from governmental authorities slowly getting around to it, and then our side trying to influence the EU level. So that was a very slow, painful process. What we did have, and this is very important in EU lobbying, we had a hook. The hook was there was council recommendations on breast cancer and other cancers that was existing, and our hook was please update the council recommendations to include lung cancer screening. So sounds like a very simple, small amendment that you can make to an existing recommendation that exists at EU level. And you can say to me, Brian, why would you bother with that? Well, once you have a council recommendation, it's not law, but what it does do is in certain countries they take it very seriously, Germany being one. In Germany, when they have a council recommendation, they have a proper committee report. How are we going to implement this recommendation? So they take it very seriously, for example. Another thing is the commission takes them very seriously. They evaluate them, they attach funding to them, which is incredibly important. And there's a kind of a peer review, peer system where countries kind of look at each other, who's doing better than others. So they can be very effective, these recommendations. So that 8-year campaign resulted in lung cancer eventually being included in council recommendations. And from that, the funding that I mentioned came, and we're part of a project that is to implement these recommendations. That's called the Solace project. So on strengthening the screening of lung cancer in Europe. Next. Yeah, the lung health checks I mentioned, this is this trajectory concept, but this also links into the NCD agenda. So the NCD agenda isn't original. It's not that the EU came up with the idea themselves. That's actually the WHO and the UN. The UN had a high-level declaration in 2011 on NCDs. They've had about 3 high-level meetings since about how to implement this. And the EU finally got around to doing something. That's this here, Healthier Together 22 to 27. In there, the big NCDs are mentioned, including respiratory, which we're quite happy about. That was another long slog to say, please give something to every major NCD, and they did. And in our case, we have a small project on how do you have early detection lung testing in schools? What can you do? How do you implement that? How do you raise awareness of lung health with children? What methods can you use to test? And is this something that could be extended into the school system, into the health system in the future? So we know what the science says, but we need to test the implementation. We have this wonderful program called EU for Health, kind of came out of COVID. Before it was around 400 million. Now it's 5.3 billion, and we have around 300,000 from that 5.3 billion for this project. Next. And this is now, those examples are specific. This is more of a general example. We set up in the last 5 years an MEP lung health group. There's interest groups for everything from beer to hunting to whatever you're having yourself. And also in the health space, there's many MEP groups. But we decided to come together with many other organizations to say that we should have one for lung health. And that kind of has a natural death with the 5 years. You have certain MEPs, some of them don't run for election, some of them have then different interests in the new parliament, so we have to set it up again. And that's our plan, is to reinvigorate or rise like a phoenix to have a new MEP lung health group, and that's what we're working on at the moment. I think the next slide. And our plan is to have a 2-day exhibition. They're called exhibitions. That's the term the Parliament uses. What we want to do there is, this is soft lobbying as opposed to the specific hard legislation examples I gave a moment ago, or a recommendation hard lobbying. This is just raising awareness on lung health, early diagnosis, showing some of the risk factors, highlighting some of the projects. But more than anything, it's trying to get the staff, assistants, MEPs enthusiastic about their own lung health, what they can do about it, how can they even detect if they have an obstruction, and they'll literally be allowed well, hopefully come down and have their lungs tested, and for us to explain the various statistics around lung disease. Thanks.
Thank you very much, Brian. For the sake of time, I think we should move to the discussion part, and I also have to pass the apologies from one of the announced speakers, Sarah Collin, who unfortunately had a family emergency and she's in the hospital. But I would like, before opening the floor for the questions, to ask Liam to maybe open the discussion, because we heard from a public health organization, we heard from healthcare professionals about healthcare professionals' priorities, and it would be great to hear from a patient organization that is doing advocacy both at EU and national level as an umbrella patient organization. So Liam, you are director of the European Public. Could you help me with with the name? With
Okay.
EPAP?
Yeah. Hi everyone. I represent, I suppose, both the national and European organisation, because I'm involved with the Irish Lung Fibrosis Association. So it's a rare chronic disease. So in some ways, I suppose the lesson I've learned from advocacy is the first thing you have to learn is pragmatism, because say in Ireland, we've been working on an opt-out for a transplant since 2008, and it was only passed this year. So I totally agree with Fraser and Brian that, like, you have to be pragmatic, it takes time, and you have to work in partnership with other people. At European level, I suppose what we've done is that we've supported the Irish group because we can sort of weigh in with scientific data or best examples from other countries, and we have a network of scientific advisors who can help us with that. So I suppose my message because of obviously time, is that, like, you know, a sad story will get you in the door. Politicians are there to listen to you, but you have to have evidence-based evidence, like an argument, to actually get past the open door, to actually begin that discussions. Now, those discussions might last years, but you have to have evidence. But, you know, use the sad story, use whatever network you have to get the ear of a politician, their assistance, and then you have to back it up by learning how to build your own capacity to provide that evidence. So, well, I'll leave it at that, because I know there might be questions, but patient organizations are there to sort of help each other, but we have to be pragmatic. That, like, you know, you can be an angry advocate, but you actually really need to get past that, be pragmatic, and get the evidence to convince people that there is an outcome that they can deliver.
Thank you, Liam. I think I heard like this underlying trend mentioned in all presentations, that to make a change, you actually need the multi-stakeholder group and the voice in one voice advocating for the health, for the change in health policy. So now I'm happy to open the floor for the questions. So if you want to raise your hand or put your question in the chat, and our speakers are here to answer. So I see there is one in the chat. Do you identify country champions to help support? Elizabeth, do you maybe want to elaborate?
Yeah, thank you. Very, very interesting presentations from both Brian and Fraser. In fact, my question is a follow-up to one of the answers that Brian gave about the work he has been doing with the council and the council recommendations. I was wondering whether, you know, I suppose you have a hook in the files that are probably looked at by the council, but do you identify country champions who help you in making sure that this is raised during the meetings? Or
So, yeah, absolutely. When we can, Elizabeth, we do. If I take the lung cancer screening example, that's almost easier for us, because I didn't dwell on it too much, but in the last 5-year term. Cancer, before COVID came, was the highest political priority of Commission and Parliament, and they had a special committee on cancer in the Parliament. So based on the nationalities of the different rapporteurs, we contacted our experts in the different countries, and some of them had one-to-one meeting with the MEPs or one-to-one meeting with the council representatives, all pressing the same message. So yes, we used country champions, and we're constantly looking for country champions because, as Fraser mentioned, you need to work the national level with the EU level, and timing is also very important. But sometimes it's hard to find the right people in the right place. We also used a lot of country champions in the Air Quality Directive legislation.
And when you say country champions, obviously these are local or national association, but does it also mean that you have the support from specific health attaché who are most likely to support?
Yeah, so some is an open door. So I think cancer for me is the example where you just have it's such a large network, but also very well resourced in most member states. I mean, they don't see it that way, but compared to some respiratory areas, cancer is very well resourced. So they have, for example, at the Commission Council level, they have what they call a sub-working group on cancer, and they meet probably every 2 months, and they discuss topics. And through our Solace project, many of the people in Solace knew who the various member state representatives were. So we were to promote lung cancer even further into the future. I don't want to say it's easier, but it is easier because the infrastructure around the cancer plan is so strong, because the ministries are well funded compared to other areas. That's an example where the country and EU level is working very synergistically.
Thank you.
Could I add as a couple of things as well? I have three points on supportive member states. First of all, you want to work with those countries that are progressive leaders that have implemented some policies nationally which are well in advance of the European dimension. So they're demonstrating the art of the possible, and they're also demonstrating that it works. So you can use them to as a sort of a peer leader to persuade other member states. And once you've got the backing of enough member states, then you're going to get much more traction at a European level. Also, when we say from a Brussels perspective, identifying other member states to work with, it's not just the coalitions inside those countries. It's not even the advocates, but also the governments. So it's the whole body politic of that country that you can try to work with, both strong coalitions of advocates at a national level and the authorities, whether they be in the Perm Rep in Brussels, but more likely the member state ministries in the capital. And then also it's important to be strategic, to identify who will have a presidency upcoming in the next years, who is also progressive and you can align with to make sure they put the item on the agenda. So it's not there isn't, again, one answer. There's a whole range of ways in which you identify who is the best member state to look to work with and who in that member state to work with.
Thanks.
I have one last question before we close. I will address it to Liam. There's a question in the chat. Can individual patients make a difference, or is it best to join a patient organization?
I mean, certainly at national level, you know, that there is that sort of relationship between your local legislator and a normal citizen. But again, it's like a national group. And what Fraser said at the beginning, there is that sort of momentum by being stronger together. So, I mean, if you're an individual patient, that you can raise your voice, you can contact your local person, but through everything, it's better if you make partnerships. So that my advice, like we've worked over the years, we've worked with many other groups outside of our own particular rare disease. And like, we're great believers in that the rising tide rises all boats. So like, where tobacco control might not be very specific to a rare genetic disease, respiratory generally helps everyone. So that's that idea of a network of partnership is one I will sort of agree with.
Thank you, Liam. And I believe with that we are coming to the end of today's session. So before closing, I would like to announce the next session of EPAP series, which will take place on the 20th of February. The registrations are open, and the session is dedicated to the launching of our 2025 Healthy Lungs for Life grants, which you can learn more about on ELF website. And I would like to thank our speakers today for sharing the insights. We can all stay in touch via social media. If you have questions, there is an email address that you can still write after the session, and we will pass them to the speakers and connect you with them if you want to discuss further. So thank you very much for being with us today. Thank you for spending this lunch break with us, and I'm wishing you a fantastic holiday break ahead, and we'll see you at our next EPAP webinars. Thank you.
Thank you. Bye-bye.
Thank you very